Hello everyone. We are Group 1A. Today we're going to talk about our study about Denmark health system. An executive summary can be conducted from our research that Denmark's healthcare system is robust, supported by a high-income economy and strong governance, but faces challenges from social inequalities and chronic diseases. To address these challenges, we propose four recommendations from different perspectives. About the goals of Denmark health system, its national goal is to build better quality, continuity of care, and geographical equality in the health system. To be more specific, the objectives of Denmark health systems are better continuity of patient care in clinical pathways, stronger measures for chronically ill and elderly patients, high survival rate and improved patient safety, high quality treatment, quick assessment and treatment, greater patient involvement, additional healthy life years, and more efficient healthcare system. However, the system itself is facing some challenges. There are shortages in health staffs, including nurses and GPs, especially in rural areas where 1.8 million people have inadequate GP coverage, and Denmark allocates insufficient resources into chronic disease prevention. These challenges need to be addressed when improving health system. Let's talk about the performance of the system. All registered residents are, and most of the health expenditure are covered by the system. Hospital stays and mortality rates have been decreased while the system guaranteed a maximum waiting time for 30 days. All these efforts reflect a high performance in terms of equity, efficiency, and responsiveness, and proven by a very high patient satisfaction. Comparing to other typical EU countries, France and Sweden, with comparable GDP per capita and similar progressive systems, Denmark shows no significant difference in health outcomes and invests the least of GDP into health sectors with the same level of out-of-pocket payment percentage, indicating its efficiency. Then let's go into the context analysis.
So I'm gonna mainly talk about several key contextual factors affecting Denmark's healthcare system, their demographics, technology, and social inequality factors. So demographically, the aging population and shrinking workforce are reshaping service demands, particularly in elderly care and chronic disease management, with medium-term impacts expected over the next 5 to 10 years. However, the strength of impact is medium to low, given Denmark's relatively robust healthcare infrastructure. And technology, on the other hand, offer medium to long-term solution. Innovation like AI-driven diagnostics and robotics are set to redefine healthcare delivery within medium to long term. The impact strength is also high, driven by culture of innovation and robust governance for data sharing. Social inequality remain a persistent challenge, even with universal coverage. This challenge can have medium-term impact and have medium impact strength. This is because of persistent inequality in access and outcome are mitigated by Denmark's integrated but unevenly distributed social care system.
Denmark provides extensive tax-funded healthcare for all residents. Universal coverage ensures access for legal residents, but low-income groups face unmet needs, especially for dental care, and rural or disadvantaged urban areas struggle with GP shortages. The system, funded and managed by regions and municipalities, ensures accountability through regulations and elections. While efficiency has improved, challenges include behavioral risk factors, an aging population, and declining productivity under value-based budgeting. Quality of care is high, with effective specialist services and low in-hospital mortality rates, but primary care inefficiencies are evident in high admissions for chronic conditions. Decentralization supports local adaptation, but complicates coordination, with new health clusters aiming to address the gaps. However, they are still in early development. But overall, the service delivery is patient-centered as the satisfaction rate is high.
Now, onto stewardship and organization. The Danish healthcare system combines centralized stewardship with decentralized organization, as seen in the graph below. The Ministry of Health oversees regulations, national policies, and financing, ensuring equity and coordination across regions and municipalities. Fund pooling and revenue collection are centralized through general taxation by the state, while purchasing and service provision are decentralized to regions and municipalities, which are illustrated on the graph to the right. Regions manage hospitals and contract with primary care providers, while municipalities oversee community-based services. Hospital care remains predominantly public with limited competition. A comprehensive regulatory framework ensures quality and safety through the Danish Patient Safety Authority, a national quality program, and pharmaceutical oversight by the Danish Medicines Agency.
As for financing part, we can see the insurance coverage graph. It shows that the healthcare system is universal, covering all citizens. However, public coverage of expenditure is limited, especially for dental care and outpatient medicines below the EU average. This results in high out-of-pocket costs and unmet healthcare needs, especially for lower income groups. Moreover, healthcare financing has both regressive and progressive elements. Out-of-pocket payments and private insurance are regressive, disproportionately affecting lower income groups. Subsidies funded by proportional income and land taxes are progressive, ensuring higher contribution from higher income groups.
Denmark's health system is largely funded through state block grants, distributed based on population size. These grants are adjusted to account for differences in local tax rates and socio-economic conditions, ensuring services match community needs. Additionally, performance and activity-based payments encourage municipalities and regions to focus on preventing hospitalizations and maintaining seamless care. This approach promotes fairness and equity in healthcare funding. The diagram on the right represents the financial flow from the state to the regions and municipalities. Provider payments. Payments to healthcare providers vary across sectors. So, public hospitals operate under global budgets, and hospital staffs are paid by hours worked, not linked to the outcomes, which may limit incentives for better care. GPs earn through a mix of capitation and fee for service payments designed to balance productivity while discouraging unnecessary treatments. Specialists outside hospitals are paid per service, but turnover caps prevent overuse. Pharmacies generate income through medical sales, with profits redistributed to ensure access for all regions. Health expenditure trends in terms of percentage of GDP are shown in the graph. So, in terms of spending, Denmark experienced a sharp rise in health expenditure as a percentage of GDP during the global financial crisis. This was due to stable healthcare costs while GDP fell. Today, in the health spending remains above the EU, EEA, and the UK average, though it may appear higher because Denmark includes more long-term care costs in its calculations.
Finally, there are 4 recommendations. Firstly, to address governance fragmentation, reduce regions and municipalities to better distribute healthcare resources, shift the focus on local care by investing in specialist training for general practice, allowing citizens to receive treatment and prevention in primary care, expand hospital clusters to improve governance, and foster public-private partnerships to drive innovation and investment in primary care. Secondly, strengthening equality in Denmark's healthcare system is essential. Coverage should be expanded for low-income groups alongside price caps on essential medicines. The block grant allocation formula should be revised to incorporate detailed health data, ensuring funding targets regions with greater needs to enhance progressivity. Healthcare financing should adopt an income-sensitive structure. Thirdly, to enhance service delivery, Denmark should expand integrated care pathways, especially for primary care, foster collaboration among GPs, hospitals, and municipalities to improve outcomes, and strengthen home-based services to
ease hospital burdens, leveraging AI and e-health can enhance efficiency, decision-making, and elderly home care support, reducing strain on the workforce. Fourthly, linking hospital staff wages and public provider budgets to quality and outcome metrics and expand incentives for GPs beyond service volume to include preventive care and patient satisfaction. That's all. Thank you.